Hello everyone, and welcome back to the channel Essentials of Acute, Emergency, and Critical Care. Today, we will discuss hypernatremia, an electrolyte disturbance that often signals significant water imbalance and is associated with high morbidity and mortality, particularly in critically ill and elderly patients. Hypernatremia is not simply a sodium problem. It is primarily a water balance disorder. Understanding its pathophysiology and management can significantly improve patient outcomes. In this video, we'll cover definition and physiology, causes of hypernatremia, clinical manifestations, diagnostic approach, and principles of treatment. Let's begin. Hypernatremia is defined as a serum sodium concentration greater than 145 millimoles per liter. Remember that serum sodium concentration is determined by the ratio of total body sodium plus potassium divided by total body water. Therefore, hypernatremia usually occurs because of loss of free water, inadequate water intake, or less commonly, by sodium gain. The body normally protects itself against hypernatremia through two mechanisms. First is thirst. An increase in plasma osmolality stimulates thirst, cause increasing water intake. Second, antidiuretic hormone or ADH. ADH promotes water reabsorption in the kidneys, reducing water loss. Hypernatremia generally develops only when these protective mechanisms fail. A practical approach is to classify hypernatremia according to volume status. 1. Hypovolemic hypernatremia. Here both sodium and water are lost, but water loss exceeds sodium loss. Examples include extrarenal losses like diarrhea, vomiting, excessive sweating, and burns. Renal losses include osmotic diuresis due to hyperglycemia, mannitol administration, post-obstructive diuresis, or loop diuretics. 2. Euvolemic hypernatremia. Total body sodium remains normal, but there is pure water loss. The most important cause is diabetes insipidus. This may be central diabetes insipidus due to inadequate ADH production or nephrogenic diabetes insipidus due to renal resistance to ADH. Other causes include insensible water loss from fever, mechanical ventilation, or due to tachypnea. 3. Hypervolemic hypernatremia. Both sodium and water increase, but sodium gain predominates. Examples include hypertonic saline administration, sodium bicarbonate infusion, excessive enteral sodium intake, and rarely, mineralocorticoid excess. The symptoms of hypernatremia are primarily neurological. As extracellular osmolality increases, water moves out of brain cells, causing cellular dehydration. Common manifestations include intense thirst, irritability, weakness, lethargy, confusion, and agitation. Severe hypernatremia may cause hyperreflexia, muscle twitching, seizures, and coma. Symptoms are usually more severe when sodium rises rapidly. Chronic hypernatremia is often better tolerated because brain cells adapt by generating intracellular osmoles to restore cellular volume. The first step is to confirm elevated serum sodium. Next, assess volume status. Is the patient hypovolemic, euvolemic, or hypervolemic? Check urine osmolality. Urine osmolality provides valuable information. Urine osmolality greater than 800 milliosmol per kg suggests appropriate renal conservation of water and points toward extrarenal losses. Urine osmolality less than 300 milliosmol per kg indicates an inability to concentrate urine and raises suspicion for diabetes insipidus. In suspected diabetes insipidus, central diabetes insipidus responds to desmopressin with increased urine osmolality. Nephrogenic diabetes insipidus shows minimal or no response. Also look for precipitating factors such as hyperglycemia, medications such as lithium, mannitol use, recent neurosurgery, sepsis, fever, and excessive sodium administration. The cornerstone of treatment is correct the underlying cause and replace the water deficit. The water deficit can be estimated using the formula. Water deficit equals total body water times serum sodium divided by 140 minus 1, where total body water is approximately 0.6 times body weight in men, 0.5 times body weight in women, and lower values in elderly patients. For example, a 70 kilograms man has a blood sodium of 160 milliequivalent per liter. His total body water will be 70 kilograms times 0.6 is equal to 42 liter. Now calculate water deficit. Plug the numbers into the formula. Water deficit equals 42 times 160 divided 140 minus 1 is equal to 42 times 1.14 minus 1 equals 42 times 0.14 is equal to 5.88 liter. This means the man needs 5.88 liters of pure water to bring his sodium level back to normal. Correct at an appropriate rate. This is extremely important. In chronic hypernatremia, correction should generally not exceed 10 to 12 millimoles per liter in 24 hours, or approximately 0.5 millimoles per liter per hour. Rapid correction may theoretically cause cerebral edema because adapted brain cells rapidly absorb water. Choice of fluids. Hypovolemic hypernatremia. Begin with isotonic saline to restore hemodynamic stability. Subsequently replace free water using 5% dextrose water or enteral water. In euvolemic hypernatremia, replace free water. Treat diabetes insipidus. Central diabetes insipidus, desmopressin. Nephrogenic diabetes insipidus. Address the cause and consider thiazides and dietary sodium restriction. Hypervolemic hypernatremia. Use 5% dextrose water with loop diuretics to remove excess sodium. Let's summarize. Hypernatremia is primarily a disorder of water deficiency rather than sodium excess. Always ask 3 questions. Number 1, what is the patient's volume status? Number 2, is the kidney appropriately concentrating urine? Number 3, is this acute or chronic hypernatremia? And finally, remember, treat the underlying cause, calculate the water deficit, and correct sodium cautiously to avoid neurological complications. Thank you for watching. If you found this video useful, please like, share, and subscribe for more evidence-based videos. See you in the next session.